Good afternoon and good morning to you if you're on the West Coast. My name is Jose Leon. I am the Chief Medical Officer for the National Center for Health in Public Housing. Thank you for attending our session number 4, Improving Public Housing Health Center Service Delivery through Cultural Competence and Health Literacy Learning Collaborative. This is a live activity, and at this moment, all lines are muted. Next slide. As I said, we are the National Center for Health in Public Housing. The National Center is funded by HRSA to provide training and technical assistance to community health centers in or immediately accessible to public housing and all health centers in general. Next slide. Before we get started, we have some housekeeping items. If you've been or you have attended the 4 sessions, thank you so much for being part of this learning collaborative. If this is the first time or you haven't attended all the previous sessions, you can go to our website www.nchph.org and you will find the slides and the recording for the previous sessions. This is a live activity. All lines are muted. We encourage participants to ask questions at the end. You can either use the raise hand icon and your line will be unmuted, or you can use the chat box and type your question. Next slide. There are 385 community health centers located in or immediately accessible to public housing, and in 2018, they serve over 4 million patients. 107 of these health centers receive funding from HRSA to provide health services to public housing residents, and in 2018, they serve over 800,000 patients. Next slide. This is a very important topic. Public housing demographics show that this is a very diverse population. 43% of them are African American, and 25% of those living in public housing are Hispanic. 52% are white, and 38% of them are disabled. So this is a great opportunity just to recap and discuss the need to provide training or outreach that is cultural competent, and just review the health literacy piece to make sure that we are offering the right resources and tools to those living in public housing. Next slide. And I am going to turn it over to Dr. Abdin Navarre, who has been hosting and conducting the last 3 sessions. So good afternoon, Dr. Navarre.
Thank you, Dr. Leon. And let me begin by welcoming everybody. Good morning and good afternoon, depending on where you are. And let me begin by saying that our health systems today are facing incredible pressures during the current pandemic, as you well know. And this is encountering extraordinary challenges, likely more difficult than any in the past. These conditions are both scary as they are also rather distressing. And as difficult as this is becoming, conditions are yet tougher for low-income persons and residents of color for many of our communities, most especially among residents of public housing. So as an introduction to our webinar today, let me be a bit more specific in framing this context for a wider understanding before opening it up for broader dialogue. As the current slide shows, these are 5 factors that I'm going to briefly review to provide this context. First, our nation faces a pandemic of incalculable proportions, one that has just begun but for which we do not yet know its duration, its ultimate prevalence, or even its overall casualties over time. Point being, seldom has the nation faced such a viral crisis absent, say, a vaccine since 1917, 1918, when battling the Spanish flu, and then for poliomyelitis during the early part of the 20th century. Altogether, however, if we look back on US history, today is considerably different. What is scary is that we may yet face unexpected surges and peaks caused by a second wave of COVID-19 come fall, if not earlier. Given recent but violent exposure from civil protests nationwide and potentially rallies that are of a political nature that may come in the next month or so. So this creates challenging conditions as rates are already grave for the most vulnerable populations, with data now documenting for people of color more than double the rate of infections and deaths overall. Now, secondly, racism that has always been present with us has just re-intensified as an additional public health factor in a bit of a different way, whether we talk about police brutality, gun violence, etc. Now, for populations of color, this is an added layer to the current epidemic, as it is also a mental health problem, most especially among Latinos and African Americans, the two largest racial groups in the country, whose high levels of police violence have been followed by still higher levels of incarceration rates and family separation. As the nation reels from recent protests for the murder of George Floyd, conditions have incentivized tens of thousands of protesters that have gathered in at least 55 cities nationwide for already more than 2 weeks. Ironically, at a time when public health experts recommend social distancing. This condition presents a seemingly discordant combination of events never previously encountered or confronted in public health, and one that may also again disproportionately affect racial minorities more strongly. Thirdly, the country is also now wrestling with astounding unemployment rates for some 40 million people, as it now also combats an economic recession barely 4 months into a pandemic. This rate is higher than previous rates except during the Great Depression. But different from that epoch, however, we are already approaching nearly equal unemployment rates in a very short period of time, with a future that has yet to unfold. So these conditions are again exacerbating already disproportionate rates for people of color or Blacks, as but one example, are increasing previous unemployment rates that had already been nearly triple the rate among white counterparts. So altogether, these concurrent conditions have put the country at a rather high risk, caught in a seemingly perfect storm of racism, viral exposure, economic downturns, safety, and public health front and center. Such conditions are not only difficult, but represent great vulnerability and high liability for the most vulnerable. As such, they will require strong leadership and maximum resources to overcome, with an utmost need for high cultural competence and renewed sensitivity to racial disparities. In general, as it now looks, our nation's welfare is locked in by a vast set of crises in public health and income inequality, with former disparities in housing and education added to the fray. health centers, and CHWs and promotoras as key members of the healthcare team have historically sought to deliberate and address the social determinants of health in order to improve health outcomes. At no time has such a need been greater. So as a result, current times call for the highest confidence in the provision of public health, such as through community health centers, as well as in outreach efforts that can improve access, promote healing, and reduce health disparities altogether. This not only means providing highly effective services, but implementing them in a culturally adequate and responsive manner. In public health, we are now facing extremely serious conditions that are unique in our history. So to this end, we have invited several community health workers / promotoras as subject matter experts to share with you their experience and help provide the context for a healthy, lively, and productive dialogue on these and related issues within the context that we are now facing in terms of communication by way of the media. So, as our first presenter, Ashley Rodriguez is a community health worker from Texas who serves on the Texas Association for Promotoras and CHWs. She is a community health worker system manager at Baylor Scott and White Health System. With over 10 years experience in community and public health, Ashley is a CHW instructor affiliated with several training centers throughout Texas and teaches continuing education to CHWs across the state. She previously chaired the CHW section of the Texas Public Health Association and has been serving on the CHW section communications and social media chair for the association since 2018. So Ashley, it's all yours. Welcome.
Thank you so much for that introduction. I really appreciate it. Good afternoon, everyone. I don't think that I need to repeat the two roles, but just for clarification, I'll be sharing both what the Texas Association of Promotoras and Community Health Workers does broadly and talking about my role as a community health worker and as a system manager for Baylor Scott & White Health, which is one of the largest health systems in Texas. Okay, so I don't want to spend too much time on the definition. I think several of you have attended previous webinars that share information about who we are. So although there's many umbrella terms, some of them are demonstrated in the image you see here in the lower left-hand corner. I do want to share with you too that Texas was first in the nation to have a formal certification process for community health workers, which nationally can be still controversial, but I am just going to share that with you. This process is overseen by the State Health Department, which requires either 1,000 verifiable hours in these 8 core competencies that are listed, or a successful completion of a 160-hour training course that covers these competencies. So in terms of what we do, CHWs nationally fulfill versions of these skills, tasks, and functions that you see here. Arguably, though, the two most well-known or most common are the trusted patient or client relationships that we build and providing resource connections. So acting as that link between the several systems to get and keep people healthy. And we do this by meeting our patients or clients where they are, through knowing their struggles, most of us through lived experience. We not only address the social determinants of health and access to care, but we also provide resource referrals in the community and conduct outreach, whether it's through targeted efforts, such as at a health fair, or through home visits and meeting with patients or clients that really need that added layer of support. And we do all of this through the lens of cultural humility. So rather than competence, humility is in an individual's personal values, beliefs, and biases that are gained from examining our own culture. We know that cultural and linguistic differences among patients directly impact their health literacy levels overall. And CHWs are critical for promoting health literacy. We're good at it because, again, we understand our community's cultural norms, and we utilize proven tactics such as speaking and writing in plain language and relying on imagery such as novellas to help guide and sometimes assess our patients' knowledge base. So as CHWs or promotoras, we can help members of our community learn how to understand complex health information and how to locate it, and also where they'll know where to go either online or in person where it's reliable and trustworthy and helpful. So there's several articles and examples nationally of successful CHW-led health intervention focused interventions. And so I have a little reference here. It's very tiny, but when these are posted to the website, you will be able to click that and see a Google search that has a plethora of these articles for your own personal use and research. One of the other things too is, when we're talking about being frontline, for frontline CHWs, providing that direct engagement and addressing social isolation. It goes so much farther beyond just doing a social needs assessment and really being able to improve that access to care. A lot of times community members don't know what they don't know until they meet with someone that really sits down and says, well, tell me what's going on, and, why are you missing your appointments, or why haven't you gone to the doctor? And then they find out, well, not only do they not have the transportation, but their cell phone got cut off. They're really struggling to just being able to take care of daily needs outside of their health. And now I'm going to talk a little bit more about what I do within Baylor Scott and White Health. So in terms of the healthcare system perspective, we've utilized CHWs for over a decade. I've only been with the organization for literally 3 years, just like a few weeks ago. But we do employ over 100, most of which are full-time staff. So we do have a small bucket that are contracted part-time community health workers, but most of them are in various care settings across our system. And I really wanted to highlight our top 5 lessons learned over the years and share with you a few of our best practices. So one thing that's really unique to our health system that I've shared with other health systems and small nonprofits and community-based organizations that are interested in developing and growing a promotora program is really starting out with, what does your internal support look like? And so over the years, we have built this Community Health Worker Development Council. It is comprised of our system leadership, some of the supervisors, and a few of the CHWs that are on the front lines. And so together, this council works to develop strategies and streamline processes, but also provide the structure and support around the programs, because none of them are centrally managed. And so a bigger part of it, and in my role as a system manager, is to develop and really help grow the leadership skills of our CHWs and provide continuing education. And so some of the key lessons learned that I'd like to share with everyone, that I think some of them look like, oh, well, that's obvious. But honestly, when you're in the middle of it and you have this grant or you have this new program or role that you're trying to incorporate CHWs to, it's not so obvious. And so when we're talking about hiring the right people for the CHW role, you really want to find that embedded, trusted community member that's probably already doing this work, whether your state has a formal certification process or not, whether it's a formal role that you have within your organization, really making sure that you're not just filling the role for somebody that says they want to do the work, but maybe somebody that is probably already doing it either through volunteering, whether it's in their faith communities, or just in their neighborhood together. They may be telling their neighbors where to go to get, free prescriptions in between the ones that they pay for and things like that. So really taking the time to ask those behavioral questions to get to know the person and make sure that they're a right fit for your organization and the focus that you want that CHW to have. And then also when we're talking about the scope of practice, or the work practices, again, this is going to vary by state. DSHS has these, what I showed you earlier, these 8 core competencies that are pretty generalized, and that's fine. But for integrating a community health worker into a care team that's already been in existence, so it may consist of, a nurse, a medical assistant, a discharge assistant, and a social worker, and a physician. Sometimes there's just struggles there. There's power dynamics, there's internal conflicts. There's also that lack of understanding. A lot of times social workers will say, well, this is what I do. And so it helps to build a scope of practice that will really allow you to see the roles side by side and what a day in the life looks like, what an MA does and starts and stops in their role and scope of practice, what a social worker does, what the nurse does, and then what the community health worker does. And when you do that, it really informs the team and they get to see it visually, but also better understand the role. And we found that to be very helpful as well. And then also, if I could, even though we don't have it this way, you know, one of the biggest lessons learned is that it would have been better for us in so many ways to have a centralized management and team structure, especially when it comes to documentation and tracking our outcomes, because unfortunately, because we've had all these ad hoc programs over the years, it's really difficult sometimes because they're documenting in different ways, and some of the managers or supervisors aren't as in tune with what they could be doing and how they could better assess those social determinants and pull out those key drivers. And so that's something we're still struggling with, and a lot of health systems have also struggled with, is the documentation piece. And also just getting that in place early on, because again, with some of those internal struggles, a lot of times what happens is you'll have a nurse that's like, well, I don't want the CHW in my EHR. I don't want them in this patient's record. I don't know what they're going to do. And not understanding that because they are a part of the care team, it's actually critical for them to be able to also document appropriately. And so building those workflows internally within your own database and electronic health record is also critical to do it early on instead of after the fact. And then finally, one of the also unique things that we've done as a health system that is part of our lessons learned, but also best practice, is building a career track. You know, we learned after about 2010 that there wasn't only one position, right? So there was it was just going to be linear. There was nothing for the CHW to strive for or to try to gain. And so we really built that career ladder. We have 7 different positions, job descriptions, and they go all the way up to mine, which is the system manager. And so, and we also gave an opportunity from that first lesson learned on hiring the right people. We have a community health worker in training job description. So that's somebody that is maybe not certified and is maybe not familiar with what promotoras do, but they can fill that role and learn as they go. And so that's something that I also think is unique to our health system. I've yet to see it anywhere else anyway. And then since I've already kind of touched on the first 2 for our best practices, the last thing is getting that frontline feedback. So asking the CHWs that are in the clinics, that are out in the community, that are dealing with those isolated and really high needs, high risk patients, you know, what do they need? And so we do this through our council and some of our subcommittees. We also have an annual job survey that's just specific to the community health workers. And we really ask them, you know, what is it that you're lacking? What is it that you need? And we take it all into consideration. We also have an open suggestion box. It's virtual and it's anonymous. And we promote that quarterly and remind all of the community health workers across the system to submit their suggestions and ideas and concerns. And then, you know, as a council, we look at that and say, okay, this is where we need to develop more strategies and start to produce what it is that they say that they're needing. And this is my contact information. Again, the slides will also be posted, but I just wanted you to know that if you have more questions about how we've built our programs or how you can also build a similar program, I would be happy for you to reach out. And then briefly, you know, understanding the CHW landscape, when we're talking about the challenges that we experience in general, whether it's in rural or urban settings, a lot of the challenges are the same for many nonprofits and other health related roles. You know, in rural, there's not as many resources, right? Just in general, there's not as many organizations to refer to, but also there's limited training, or even in our case in Texas, continuing education opportunities, because our CHWs do require to have so many number of hours every 2 years. And then there tends to be less support. There's not always, and this is part of the reason why the Texas Association was established last year, was to provide support for those CHWs that are kind of isolated and don't have a local association to support them. And then in the urban areas, you know, a lot of the times the opportunities are just stagnant. There's not as many roles or jobs or even outreach opportunities for CHWs, because a lot of us do this on our own time. I know I not only volunteer, but I serve a number of organizations and do a lot of education and outreach on my own as well. And then finally, and this could fall across all the buckets, is there's a lot of utilization and underutilization of CHWs and outreach. And then generally, you're still looking at organizations to say, well, I want to know what the return on investment is. I want proof that this works. And, one of the things I say as an advocate of my own role is that you don't ask that of nurses. You never see that you have to provide data of what nurses or social workers or even sometimes community outreach workers that don't have the umbrella or title specifically as a CHW or promotora, they're not asked for these things. And so that's one of the main challenges that we have for this role. And I've already talked about the integration of care teams. And then, this was already touched on earlier in the introduction, but with the current COVID crisis, we saw that a lot of our CHWs that are used to going out in the homes and being in the community, they were instantly thrown into telehealth. And then, unfortunately, a lot of their patients either mistrust technology or didn't even have access to it. And so as the clinics were temporarily closed, they had a new barrier or challenge to overcome. And it was unique to see how some of them did it. Some of them did go out into the homes and knock on the doors and say, hey, I want to talk to you about this. And this is why we want to do this. We want to keep you safe. I'm going to stay outside. I have my mask on and I can call you, but it would be easier if I could see you because then it'll feel like we're in person. And let me show you how to use this app and let me walk you through it. And then for those that didn't, they were like, I'm happy to call you and we can work this out. And same in, some of the language barriers were also exacerbated. So if it wasn't a Spanish-speaking patient or some of the other Asian dialects that are more common, that they're having to use a language line, and that can also, make the patients less likely to want to interact or answer the phone when they know that it's going to be delayed and there's an interpreter and it's less personal. And so we're seeing, we saw some of that as well. And then finally, also the CHW's role in combating the influx of misinformation about all the things that were changing in the state, things that were changing locally. I know in North Texas, every county does their own thing because we're a home rule state. And so Dallas County, have their own rules and advisories and what was shut down and what wasn't. And Tarrant County had something completely different. And so they're having to provide a lot of that ad hoc education too that was changing by the week. But finally, I do want to leave it on a positive note in that there are opportunities and solutions for utilizing community health workers because they offer a lot of that coordinated outreach efforts that a lot of organizations are looking to tap into. And we're excellent at outreach, whether it's virtually or in person. We roll with the punches and we're great problem solvers. And then we're able to extend the reach of healthcare and social services in general and delivering those culturally appropriate services. And I mentioned this before too, but addressing social isolation, which is even more important now than it has been in the past. And finally, the last thing that I'll leave you with, which again, these will be posted to the website from the Learning Collaborative, all of these resources that are listed here. So just a few that are for those that are looking to build their CHW programs, for those that want more information on health literacy specifically and some components to build into or do an assessment of your organization and what you're doing around health literacy or what you should be doing. And then finally, some on cultural humility. I think that it's still relatively new for folks to understand that term because we focus on competency, but I highly encourage you, especially this second link here is a class, and it's fantastic. I took it myself not that long ago. And then here's some general information about our association. You can reach us at our website, www.tapcha.org. And I appreciate your time, and I'll speak to you again during the Q&A. Thank you so much.
Thank you, Ashley. And for those of you observing and looking at the resources, I just want to underscore that these are live resources or live links that you can access afterward when you receive copy of the PowerPoint presentation. Now, our other subject matter expert and presenter is Floribella Redondo, who was born in Mexico and migrated with her parents to the US-Mexico border, where she was raised and from where for over 20 years worked at harvesting lettuce fields alongside her family, with ongoing migration between Arizona and California. It is through that experience that she began her journey as a promotora de salud, educating her farm worker peers, for example, on HIV and STDs. Today, after 25 years of work as a promotora, she is co-founder and executive director of the Arizona Community Health Workers Association. She is a state-appointed CHW Advisory Board member for Arizona's CHW Voluntary Certification. She is co-chair for the C3 National Core Consensus 2 project, or phase project, and also board member for the National Association of CHWs. Lots of hats that she has worn. And so without further ado, let me turn it over to Floribella Redondo. Welcome.
Thank you so much for the invitation, and thank you, Ashley, for that great presentation. So that allows me to not repeat many of the things that you have already mentioned. So my presentation will be focused in a little bit different. So I'll be talking about more the role of what we have done before and what we do now. Again, thank you, everybody. My name is Floribella Redondo, and I'm really happy to be here. So one of those things that I want to talk about is the CHW service delivery. We have made so many differences since we began back in the early 90s when I became a CHW promoter, a volunteer CHW promoter, which I was paid $25 a month for providing services to my peer farm worker population. Now we can see the great strengths that we have developed and the great recognition that we have around the nation and globally. We have also many other things that have come in place, the unity of CHWs, promotores CHRs under one umbrella, the National Association of Community Health Workers that now has been developed to be there as the strength and the umbrella for all other CHW networks and associations and groups. But many of the things that we want to talk about today is what are the things that have not changed? One of the things that have not changed, I want to really talk about, we want to make sure that we understand that when we began as a CHW, we were the promotores de salud, we were the volunteer promotores, the average promotores. But now we can see with the Unity tree, we can see so many of the titles that are being utilized, and we are integrated into that umbrella that identifies us as one workforce. So what has not changed to date as a CHW myself, and I continue to see this with our CHWs that are working in our community, with our state, and many other things that we hear in meetings, and many of the trainings that are still being provided and required by CHWs. One of the things is that we need to continue to develop the understanding of the services that we're providing and the community that we're providing it to. We need to look at these communities with the understanding and the respect of we're all from different cultures, that we all come from different places, different struggles. Still, the CHW role that Ashley has identified, we can actually address all those issues because we have the understanding, we have the commitment, we have the training. But one of the things that we still see is that we tend to not recognize that there's many different cultures. And a lot of times because we live in a specific community, like in the border community, we tend to think that everybody is the same. We come from Mexico, we live in the border, so we actually have the same culture. The fact of the matter is that we don't really make ourselves aware that there's no one culture that identifies one population just for living in one community. We're always going to be going back to making some mistakes that we made before, that we didn't have the guides that we have now to make sure that we integrate, that we address, that we provide, and that we service our population with different needs. And one of the things that I want to make sure that we need to be informed. We need to be informed And we should never think that we know everything about cultures in our community. It doesn't matter if it's my neighbors, it doesn't matter if it's my peer that was working in the fields. We have so many different cultures that we actually identify ourselves with, that we need to always, as CHWs, make sure that we continue addressing that and making ourselves really an expert in doing that. So one of the things I want to talk also, how the role of CHWs in continuum of care has changed. And talking about the CHW role before, we did provide education, we did outreach, we provided the outreach in communities and left pamphlets, and we knock on doors, and people wanted us to go into their homes. We did home visitations. But nowadays, we now have this role in the continuum of care and the direct care of our clients, of our patients. One of the things that we do really good is identifying the need, is making sure that we know where the health inequalities or the boundaries, the challenges in our community are there in some specific zip codes, that we want to call it that way. But we know it's in our community, in our neighborhoods. One of the things that CHWs can really utilize for this is the CHW skills of the C3 developed. The roles that we provide is really based on the skills that we have. So when we think about the continuum of care, we identify, we work, we visit our clients, our patients for maybe one time, maybe weeks, maybe months, maybe years, before that particular patient client is able to be really engaged and to do the right thing and to go to get services. And many times, like Ashley mentioned, there's a lot of challenges for them to do this. There's a lot of challenges because no health insurance, the transportation limitations in some of the rural areas, the ability to go to a clinic and be able to pay for that service if they don't have the health insurance, or even the fact of deciding if they buy medication or if they buy food this week. So we know that CHWs work in that continuum of care, that before part. And then we know that once we're being engaged and we provide them that opportunity to go to the provider, a clinic, we open the doors through the access to care, they do get that time with a provider. And but after they leave the provider, we are there again. We are there following their information that they got from the provider. Are they able to pay the medications? Are they going to be able to pay their housing payment this year or this month? Are they going to be able to really think about buying the medications as prescribed? Or are they going to be taking shortcuts? And living in the border community, I can tell you that cultural humility is such an important part in this area. When we're thinking about CHWs and providing the care, we need to be very culturally and informed and be able to understand that when we see our clients, our patients, and they do have this prescription that they need to fill out, and many of them are not able to buy it here in the US, many of them cross the borders. Living in the Mexico border community really provides a lot of opportunities but a lot of challenges that we need to be aware of. One, many of our clients do not get their medications here, but they do get their medications across the border, which it comes to be that there's not exactly the prescription that they had to be filled in. So one of the things that happens is that they get a medication over there, it doesn't really work, they go back to the doctor prescribes another medication, then they get another medication, so they never stop taking the first medication, so they're over-medicating themselves. So the care coordination aspect of the CHW's work here is really important. And cultural humility is really to understand that we really don't understand what's going on with our community, that we are really there to learn. Every single day we learn from our clients, we learn from the challenges, we learn from the community itself of the experiences. But it is so important that we understand that we don't know it all. We don't know it all. We still play such a great role and such an important role in the continuum of care, but we need to prepare ourselves. We need to make sure that we understand that we never are truly informed of what we need to be doing. We are in a learning process every single day. So why is health literacy important? And what can we do about it? One of the things that CHWs is, before we didn't think about health literacy. This has changed so much. Now we understand that health literacy is really important because it really provides you a picture of the health of the individual community that you're serving. So as we see here, patients with low health literacy are more likely to visit an emergency room. We know that now. We didn't know that before. We went to visit Mr. Rosales, and he would be really happy to see us, and he would be opening doors, and we would be providing information, and we would leave the information there. We knew that he might have some challenges in reading, but we didn't really know the true impact of the low literacy in their health. Now with all the training, all the things that have been developed for the CHW workforce, that with the recognition of our profession, now we know that everything's linked to how we understand, how we process our health with the information that we're provided. That's why it's so important, the role of CHWs and the follow-up after they see their provider. Are they really truly understanding what the doctor said? Are they really truly understanding that they cannot be by themselves at their homes? Are they really connecting with their family as a social support so they can be there, so they can actually have that support to maybe buy medications, maybe to go to the doctor for a follow-up appointments? So we can see that health literacy is so important, but also that it plays a major role in the health of our clients and our community. And it's so important that we continue looking at this as one of the biggest and more important roles that we play in our community when we inform, when we provide, but also when we engage and refer our patients to different clinics, different organizations. So I want to talk also about the roles of CHWs in pandemic, and of course, thinking about all the things that are happening right now across our nation. One of the first things that came to mind about this was when we learned about this epidemic back then. And we were hearing in other states that was happening, but because our states were not impacted, we were still kind of doing our own work and continue with our own roles. It wasn't until this was declared a pandemic and that every single state provided its own mandates that we began thinking about, okay, what does it mean for us? How does it change? How does it really truly modify the role of CHWs in community settings? We know that many CHWs were laid off, many were furloughed, many lost their jobs just because there was no opportunity to have contact with clients. I think that this is such an important thing to talk about because it really allows us to think and to understand how CHW organizations, clinic, and health systems were not prepared. Even though we think about integration of CHWs into healthcare teams, and we think about that's so great and it's happening, we can see that there is still a lot of inequalities in the integration of CHWs into healthcare teams. We still need a lot of training, not only for CHWs to understand the roles of CHWs do not change within the clinical setting. We need to understand also how CHW managed supervisors see the integration of CHWs into the clinics And why was it the CHWs were the ones that were laid off and furloughed, and not the nurses, and not the doctors, and not the psychologists? So it is important to think about why is it that still at this level that we have been recognized nationally, we're still seeing the role of CHWs not as important when it comes to healthcare and the integration of CHWs. So the development of many of the tools that CHWs had to really think about. So because why do CHWs need to think about this? Because they are the ones that were engaging, they were the ones that know, the ones that connect, the ones that understand the community and their clients, their patients. So by identifying what can I do now, what is my role, it was not only to provide a service back to community, it was a way to make sure that their role, their job was still there. If I can produce a way that I can continue working, my role, my job will still be here. So thinking about this, it's really important that we really make organizations accountable to making sure that CHWs are trained, are recognized, and they continue being treated as a profession that they represent. So in our part, what we did to respond based on the CHWs here in Arizona, we developed some outreach questionnaires. So we want to make sure that we continue looking and connecting with our clients, making sure that they are there, that they are aware that we continue to be there. So we also kind of started developing mental health webinars. No money involved in any of this. But why? Because once you're a CHW promotora, you know that there are things that you need to provide regardless if there's funding or not. So when you start looking at this and people start looking at the things that you're doing, then the funding comes because everybody wants to be involved and want a piece of the development of its manual or the webinars. They want to have their logo. So people come once you develop something, and once you have CHWs involved in developing the response to a pandemic, to emergency, whatever it is, you will have specifically what the community needs in that moment. So I want to finalize with this. One of the things that Arizona lessons learned for us is that we continue to be a strong workforce. We continue to be a workforce that's out there in communities, not hundreds, thousands every single day providing services. But yet we know that there's not a lot of recognition, and as we've seen, once there's some struggles and challenges, the first ones to are being laid off are the CHWs. And that's one of the things that we need to change. That is why our Arizona went around for a couple of years. I spent going around the state and talking to CHWs, CHRs, promotores, and asking them, what do you want? We need to have the voices of the CHWs represented in every single thing that you develop in your state. And because if you bring CHWs together and you strengthen and unite the workforce, you will be stronger in changing policy, in bringing equity and equality and onto our workforce. So one of the things that we did, we went around to other states and looked at other states on what they have done for their volunteer certification, accreditation. And we learned from what worked and from all the challenges that they had also had. And so we decided to visit 3 states, and we got a really good data of the things that we wanted to stay away from. So one of the things that we decided in Arizona is the first thing is that CHWs need to be the driving force and the voices into bringing CHWs as a workforce, as a profession, as a recognized profession. That possibility of also getting reimbursement for their services is really knocking on our doors. So just thinking, and I'm just trying to get through this because it's really late already, but just wanted to say that Arizona developed this training and program that allows CHWs to get training on CHW core competencies, because still, even though we have the core competencies, many CHW organizations do not provide this type of training. They just provide the training for CHWs, specifically to the direct service that they're going to be providing to the program directed by the grant. So CHWs are still not really being trained on what their profession is. So we wanted to make sure that everything is tied into our volunteer certification. So CHWs organizations, they need to train their CHWs if they want to qualify for the volunteer certification of their staff when it comes to fruition. So I think that with that, I just want to say that thank you so much. I know I went too fast. There's so many information that I wanted to provide, but one of the things, the most important thing is that we as CHW, as workforce, we're here. We are not going anywhere, but the opportunity is for all of us. But we need to make sure that we continue learning every single day, and never think that we know everything, because we don't. We don't. Every single day, it's a learning process. Thank you.
Floribella, thank you. That was excellent information. Lots to gather. Limited time in terms of our Q&A. So let me turn it back to Dr. Jose Leon.
Thank you, Dr. Navarre Ramos, and special thanks to Ashley and Floribella for their presentations and the great information that they provided to all of us today. Before we get into the Q&A session, I just want to remind the audience to please complete the post survey after the webinar. There is a brief survey. Let us know how we're doing, and provide feedback, on this learning collaborative, and what you would like to see, or what additional information you would like to get in the next months. So again, we are going to start the Q&A. At this moment, you can either type your question in the chat box, or you can use the raise hand icon and your line will be unmuted. We are going to give a few seconds to the audience to either type their questions or use the raise hand icon. And in the meantime, I have a question, and this is for Ashley specifically. Ashley, when I was looking at the slides, you have some challenges and some responsibilities for CHWs. And one that is very important is the health education piece, because now in this ever-changing healthcare system, CHWs are being called to provide health education. There are several emerging issues like diabetes and mental health, and for the Hispanic population in particular, we have cervical cancer. And CDC, for instance, has developed a program for CHWs. So in the future, what do you think the role for health education will be for CHWs, and what limitations they will have or challenges they will have to face in the future?
Yeah, great question. There's a lot of resources nationally now, more than ever, for community health worker training in various topics that range from, as you mentioned, chronic health conditions to mental health. I think, there's a lot of opportunity in finding both online training opportunities and building in the knowledge base and the various competencies. I know within Texas too, we're also a little unique in that we do have two certifications. We have one for community health workers and promotores, but we also have one for instructors. And so those are for the CHWs that are doing community-wide teaching and education, but also for them to instruct each other. And so a lot of the developmental things that I provide in our health system, and also from the other organizations from the state and a local one in Dallas-Fort Worth in North Texas. I develop curriculum based on the needs that I see and feedback, but also in quote unquote kind of the hot topics or popular topics. And so some of the things, of course, I'm seeing float around now is CHWs as contact tracers, and what does that mean, and what kind of resources are available. NACHWA, the National Association, and Floribela can probably piggyback and add more information, but they've had several virtual trainings on this topic specifically. And then for CHWs in general who are providing that community education, just I think one of the things that is important to understand is most of them are just like finding it. They're locating the information, they're educating themselves, and they're finding these trusted and reliable resources like the CDC or the National Libraries of Medicine, just to name a couple. I mean, there's several that they look to. You know, the WHO. There's so many organizations that can provide general information and education that not only the CHWs find value in to be able to better do their role, but also to educate their communities and patients. And I hope that answered your question.
Yes, it did. Thank you. And any additional thoughts, Floribela?
No, I agree with Ashley. There's a lot of trainings already out there developed, and one of the biggest I think contributors to this it's Betsy Rodriguez from CDC. So I know that we've been working with her, and we're still right now working in a smaller group developing curriculum for CHWs to respond to COVID-19. So there's always opportunities, and every single state is actually looking at what is specific tools they need to respond to this pandemic. And of course, everything's going to be different, and the CHWs need to be involved, and they are involved in many of the states. So I just continue to recommend, I always say, when you develop something, make sure that the voice of CHWs is around the table, and it's really important to connect to what's really happening in communities.
Thank you, Floribela. Ide, any questions?
No, not at the moment.
No questions? Okay. All right. There is another question that I would like to ask Ashley, Floribela, and this is about a topic that we know it's there, you know, but we don't talk, and this is regarding the Hispanic population and the traditional medicine. You know, and we've been discussing health literacy. We've been discussing whether or not patients are able to understand instructions or prescriptions from the providers. But one of the biggest issues that I see as a provider is how to deal with traditional medicine, you know, the use of medications or ancient medication that I'm talking about some herbs and other homemade drugs that is common in the Hispanic population. So do you offer any training, you know, on how to deal with this type of medications to the CSWs? I'm just curious.
That's a great question. You know, unfortunately, in my health system, we're not exploring anything like that. But I will say I've seen some really fantastic programs, especially in the southern border region of Texas. I know that there's a program out of the University of Austin, actually. There's a gentleman that's also a community health worker, and I believe he has a social work background, but he works to connect the curanderas in the area with his local health clinic, and then he's also a professor at the university. And so I've seen a couple of models like that. And then in terms of holistic health approaches, where you're using natural remedies and relaxation, meditation and things like that, it's definitely becoming more of a hot topic. I know that I just used a curriculum, if you will. There's a a deal out of the National Libraries of Medicine called Know the Science. And a big part of it is actually understanding complementary health approaches and what that means, and understanding, where you can find reliable information on that. And so I did develop a 1 hour, actually no, a 2 hour continuing education class that I want to present statewide, hopefully next year. And so I'm excited about that, because I know that this is something that I've heard in conversations, but not necessarily seen on a national platform or even statewide where anyone's talking about it. But in one-on-one conversations with CHWs, especially from the Latinx community, there is a lot of interest in understanding how we can connect those better.
Great, thank you, Ashley. Do you have any experience, Floribella, on this particular topic?
No, well, one of the things that I agree with Ashley, there's a lot of, the closest that you get to Mexico, the more that you're going to be hearing these stories. And one of the things that we have seen from experience is that many our clients still utilize the home remedies, and regardless of what medication they're taking. So many times they do go to the doctor, and the doctor will tell them, "Oh, what are you doing? You're doing great. What have you been taking your medication?" So there's not a lot of connection on what's happening at homes with the home remedies, with the actual outcomes of the patients. But in another instances, we have also seen that some of our clients mix a lot of the home remedies with their medication, and that really also becomes a challenge to the health of our clients. So there is no regulation, there is no training, and there is no program right now in our communities that can provide that knowledge and skills to our CHWs to work around the home remedies and in a factual and structural way. I think that we all know about those because we are part of the community, but there's no training for us as of right now.
Excellent, thank you so much. Let me go back to Fide. Fide, any questions?
Yes, so we have a question for Floribella and Ashley. What major impact stands out to you that you have seen in the communities you serve as a result of CHW outreach?
What major impact?
Yes. What major impact stands out to you that you have seen in the communities you serve as a result of community health worker outreach?
I think that one of the things that we've seen is the reach and the respect and the recognition of our CHWs within our communities. I think being the outreach, the CHWs become the essential workers for our communities, not only right now through this pandemic, but through all of our lives, really, that we have been serving. CHWs are the recognized individuals and that are trusted. And as we talk about CHWs, we know that it's because they are out there every single day fighting the dogs, or maybe walking without water or shades, but they're still reaching out, and that it really becomes a respectful gesture from communities that see them and they recognize them. And what we've seen is the increase of CHWs reaching a community, but also the increase of clients and patients going to their healthcare appointments. So I think that we've seen a big impact both ways, and that is really important for us.
Some of the impact I've seen is, and I know we're getting that close to over time, but some of the impacts I've seen too that I wanted to quickly share is also that that connection to those community and faith-based organizations and government agencies and how they build those partnerships. For organizations as large as mine, we employ 48,000 people in the state of Texas, just to give you a snapshot. We have over 800 touch points in healthcare. And so it's a really complex task for us to maintain working relationships with those social service agencies. And it's the same for them, but our CHWs are on the front lines that are going out into the communities and really providing education or outreach directly. They are the ones that are the stewards of those relationships. And so from a health system perspective, they're critical. And I could say the same for the other organizations that I serve. One of the major impacts that we've had in our members from the state association is just getting us better connected to those that maybe aren't official associations that support the role, but they are allies that have a lot of contacts and information and can help us spread not only ideas, but those greater connections statewide. And so I would say that that's the major impact that stands out to me in terms of their relationship building, going beyond patients and clients, but to the greater community and to other organizations.
Excellent. Thank you, Floribella, and thank you, Ashley, for your responses. Any additional questions, Sire?
No.
No questions? Okay, I just have one more question. Dr. Abdin Navarre Rios mentioned current public health issues. He mentioned community violence and racism. And there is something that is related to COVID-19, and this is the public charge. Both of you are very close to the U.S.-Mexico border, and have you been training CHWs on this particular issue, and so the community that they are with understand that during the COVID pandemic they can get tested and they can get any additional services for COVID-19?
We have, and we have put some webinars as well, making sure that through the Mexican consulates, we provide the information, and we have CHWs there presenting as well. However, it is really difficult to serve a community that has been for generations being racial profiled and really having living in Arizona is really a super red state. So we're kind of used to being around this racial profiles and discriminatory actions from organizations within our community, even for our community members. So we have not seen really an impact on having some of our community members getting tested or even thinking about it, just because there's not a lot of trust in the system. There's not a lot of trust in the system, and of course they're not going to be. There's been some experiences in Arizona before, and where there's been a lot of outreach and communicating the information to our community, but yet once they go to some different places, is something totally different, and they get arrested and they get deported. So our community members are not trusting the information, and that's really a challenge for CHWs. However, we continue providing the data, and then they say, well, it looks really good on paper, but it's really happening in the actual community and the actual services. So it is a challenge to make sure that they understand that they will be safe and they will not be reported and all those things that we know. But as of right now, the trust is an issue, right?
Excellent. Thank you, Floribella, for your response. All right, Fide, if there is no additional questions, that we can move on. Next slide. So we've been analyzing health center data on COVID-19. You can see the latest numbers provided by the community health centers, and these numbers are specifically for those health centers located in or immediately accessible to public housing. If you would like to access these fact sheets, you can go to our website, and you will find under the COVID-19 subtitle, you can access all these resources on COVID-19. Next slide. You can also visit our website, and you will find, in addition to the COVID-19 updates, additional information on webinars, publications, and interactive maps, and information on one-on-one training and the annual symposium. Next slide. You can also join our mailing list, and you will get information on HRSA updates, Medicare updates, information on senior programs, and other resources and services. Next slide. So please complete the post survey, and if you have any additional questions, please feel free to contact any of our staff members. We are here to help and to respond to any of your training and technical assistance needs. One more time, I'd like to thank Dr. Abdino Barrios for hosting and conducting this Learning Collaborative series. And I would like to thank our two panelists for today's webinar, Floribella Redondo and Ashley. Thank you so much for participating, and once again, thank you so much for attending this event. Have a great afternoon.